immersive VR and AI are not about replacing nurse faculty or educators. It's really a tool to help us make student thinking very visible so that we can coach them in learning clinical judgment. We can assess them better. We can measure their progress.
Simulation is evolving, and the future is here. Discover how intentional design makes immersive virtual reality a game changer for nursing programs and empowers faculty to transform classroom learning. Welcome to Lippincott Spark, Illuminating Nursing Education, the podcast that fuels teaching, innovation, and leadership. I'm Dr. Kelly Drees. Each episode, we spotlight bold ideas, expert voices, and practical strategies to help you teach smarter, lead stronger, and stay inspired. Let's spark new thinking and dive into today's episode. Imagine a world where nursing students step into lifelike clinical environments without leaving the classroom. Immersive virtual reality isn't just a new technology, it's a new way of thinking about how nurses learn. When we design with intention, immersive virtual reality becomes the bridge between simulation and real-world practice. Today, I'm absolutely thrilled to welcome Dr. Cynthia Bradley, Associate Professor and Director of Simulation at the University of Minnesota School of Nursing. Widely published and nationally recognized, Dr. Bradley is pioneering the use of immersive technologies and artificial intelligence to transform nursing education, bridging technology, pedagogy, and competency-based assessment to prepare the next generation of nurses. Welcome, Cynthia.
Thank you so much. Thanks for having me on here.
I am excited to talk to you about immersive virtual reality. So let's start by exploring your personal journey into this space. What is immersive virtual reality and what first motivated you to explore it in nursing education? And I'd love to hear how you see it changing the way students develop clinical judgment.
Yeah, so, we've seen this real uptick of virtual reality or extended realities. So I think that, one thing I and my team have been really intentional with is actually defining what is immersive virtual reality so that we all understand what we're talking about. Immersive virtual reality is when you are in a headset that puts you into a virtual environment so much so that you feel as if you are in that environment rather than your physical environment. So I'm not talking about the VR that is done on a computer, on a laptop. I'm talking about full immersion because there is a lot of science behind that has physiological impacts on our brain. So that's the type of experiences we're trying to create for students. So I've been involved in simulation for quite a while. So traditional high fidelity mannequins, standardized patients, unfolding scenarios, kind of the gamut as we all have been in nursing education. And when I started in simulation, I was in a small school where it was a bit of a change fatigue. I'm hearing that phrase a lot. There was a lot of resistance. But I think, fast forward to 2025, we have wide agreement and a lot of data that shows, simulation, the learning is as good as clinical. I think most of us in simulation would say it's actually better because we can provide those consistent, standardized experiences. We're all getting training in guiding students in a reflective debriefing. We have the healthcare standards of best practice now, and programs are adhering to that and providing professional development training for faculty. So I think we've come a long way in giving students really meaningful clinical learning opportunities. But we have this new technology with VR. And I think, VR is not new. It's been around for decades. But what is new is that as the price point has come down and as we've learned more about it, it's just a more feasible option now. And I think we're getting to the point where it's probably more feasible and cost effective than doing the in-person simulation. The other thing that really excites me is that the accessibility. There's so many places that do not have access to a robust sim center or have any mannequins or people to do it. But VR, if you understand how to use a headset and you have access to software, you can provide those standardized, consistent experiences for students that we cannot guarantee in clinical. And even if they have those experiences in clinical, we're human beings. It's very difficult to ensure every student has the same learning experience and the same opportunity to be assessed, for their clinical competence to be assessed. We just can't guarantee that, which leads me to the last part of your question about clinical judgment. So much focus now, measuring clinical judgment, competency-based education. I really see immersive VR as one way to achieve all of that, because it's a computer program. So when you do VR and you click on tasks, you select the things that you're doing. So all of your actions, all of your decisions, they're being tracked. It turns our measurement into something that's much more objective rather than very subjective, depending on each clinical instructor, you know?
And we're seeing that in our Lippincott VR clinical by embedding the conversational AI, and really it's just a game changer. Kind of building on that, when we talk about integration and adoption, you know, many programs are really curious about how you integrate it. What lessons have you learned about introducing IVR into the curriculum, and how have you seen students and faculty respond?
Wow, so that is a big question. So I will say the response that we've had from students has been very overwhelmingly positive. I've been leading a project where we designed some multiple patient scenarios that we integrated into our senior courses. So I won't tell you the whole story, but it took a good 2 years to develop these. So from the time that we started to when we actually did it with students, there was so much blood, sweat, and tears that went into all of that. So when we first did this with our first group of students, the excitement in the room was something I've never seen in nursing education. And most of their excitement was that they were the nurse. They were there individually, independently. Nobody's watching them. Nobody's instructing them or guiding them. They could make their decisions. And even though they made mistakes, they were still so excited because they felt like the stress of it. I had one student say, I was so stressed because I knew that this patient was depending on me. And they said, my hands were sweaty.
Okay, sure.
But that kind of speaks to, we're creating this very immersive experience where they feel as if they are the nurse. That's what we're looking for. So when we talk about integrating this across our curriculum, there's really 3 big buckets of challenges that we've learned about, but just we've learned how to do it. So one is the hardware itself. The second is the software you're using.
Sure.
And then the 3 is really the pedagogy, like what supports all of that. There are many pieces with each of those that we've learned so much. We are still learning. And so, you know, I am quite passionate about making sure that nurse educators have the tools that they need to teach well so that students learn well. I'm hearing a few stories now, though, of programs who are starting to use VR where they've had no training. They've had no time to test out software, the hardware, and those experiences are not going well. I'm very passionate that we don't have that.
Mm-hmm. You know, as we kind of dive into that intersection of, we mentioned AI or artificial intelligence and IVR, you know, how are you using that data? Can you share a little bit about how the combination of immersion and analytics help educators better understand kind of student performance and readiness? Because we know there's limited classroom space, there's fewer clinical preceptors, clinical sites, you know, there's not enough faculty, there are resource constraints. And then as you try to use this data to make sense of it all with student performance, and are they ready for practice? Like, how have you seen that kind of intersection between AI and IVR?
I think depending on the software that you're using, it seems most of it is AI driven in some way, whether it's just a very basic form of adaptive learning, which is not new. We've had that for quite a while. But what we're seeing a lot more now is that it's very individualized. So what a student notices first, the first thing they assess, the first patient they take care of, your prioritization, what you delegate, those things are being, you know, there's AI models that drive that. The other piece of that is the data that's generated. So, you know, again, it's kind of dependent on software, how that data is analyzed and presented to the students and to the instructors. And so, you know, that's a whole thing in itself, just an ability of being able to not rely on objective ratings, checklists, even in simulation. Yeah, we have consistent scenarios, but trying to evaluate students consistently, it's just very difficult to do. But in IVR, students can have very individualized experiences that are AI driven. And then we have data that shows exactly what they did. So there's no arguing. So it's really taking their thinking and their actions and putting it into something very concrete with this data that's generated. Then what I've been kind of playing around with is just dumping all of that IVR generated data into AI. Now, I'll qualify that with you have to follow the guidelines of your facility, your university, we want to protect our students' data. But once you've, gone through all of that and you have the permissions and you're able to use, we have our university version that's kind of locked down just for the university, but putting it into there and then just putting in the clinical judgment measurement model or whatever competency tools that you're using so that you train your model on what is clinical judgment, and then just beginning to look for trends, looking for gaps, across a cohort. Are we seeing that everybody is not doing their rights of med administration? Or are they all really nailing safety, patient safety, but really beginning to look at trends from one student from, maybe one scenario to the next scenario. So looking at individuals over time, but then also looking aggregately, how is each cohort doing? Because each cohort is so different. So I feel like we're just touching the tip of the iceberg. I think our vendors will have more robust evaluation of that data, but this is all so new. We're all diving in. We're all just trying to figure it out. Have these two great technologies. And I think that kind of fusing them together, it's really going to help us understand clinical competence, clinical judgment, so that we can intervene with students and really be able to strengthen where those gaps are.
I can't agree with you more. I mean, this is with the research that we've done and the development we've done with a lot of the Lippincott products. We've seen how to use that data to really hone into an individualized approach for that student as well. Because we know the real world pressures of nursing practice is constantly evolving, right? And especially when they're faced with caring for multiple patients at one time, and they might not be acclimated to that, especially as a new grad. But if we can get them that experience using virtual reality, those clinical experiences, I think it just helps them gain the confidence and the skill set to be able to practice safely when they get out there. So what challenges have you seen that educators might face when adopting IVR and maybe AI technologies? What strategies have you seen help overcome some of these barriers?
Yeah, so I think that kind of goes back to what is involved with integrating, because that's where we find our challenges. And, how can we help? How can we make that better? So starting with the hardware, selecting headsets, it's not just acquiring the headsets, it's how do you connect them? We have issues, and this is probably not specific just to us, but if our headsets connect to the guest network, the scenarios don't run well. So we've had to figure out how to make sure they don't connect to the guest network. How do they connect to the network we need them to? Those things are difficult to figure out, especially say you're in a smaller nursing program and maybe you are the only one doing VR. No one else in your entire university is doing VR. You have to figure that out. You're the one who's got to figure out how to make those headsets connect consistently. Meta releases updates. So on the Meta Quest, you have to make sure those updates are done. There's just a lot of things. Charging them. Do you let students take them home? Those are things to work through. I think now that there's enough people who are doing VR, that we have some publications out that we hope will help with just that piece of just the hardware. Then you have the software. What scenarios do you need? And then just the pedagogy. How do you integrate that? Where do you start? I've heard some people say, we're going to start in the fall and we're going to integrate IVR across our entire curricula. And I say, please,
That's a little daunting. Yeah.
It is like, I love the attitude, of really wanting to embrace this, but start small, start with one course, start with one topic in one course, do it well, like really know what you're doing, really understand how to orient your students, because you have to orient them to the hardware, but also the software. It's two very separate things. So we've kind of found some ways to do that make it a little bit easier and fun too. There's fun apps that you could put a student in just for 5 minutes. It's, there's one where you're a pirate, but it really teaches you how to move with the hand controls, how to, your eye gaze, how your head moves, tracking in a really fun way. So if we do something like that first, then they understand how to use the hardware. Now we move on to the software. Then we learn how to do that. So I think, pedagogically, we're looking at integrating according to the healthcare standards of best practice. We're doing a pre-brief, this is a form of simulation.
Yep.
We do our student prep, we do a pre-briefing, then we have the students go into the headsets individually, and then we debrief after that. Does it change debriefing? Yeah, a little bit, but I think there's a lot of ways it like changed it for the better. We get more student interaction now. I feel like we have less quiet times. So those are the things, though, to kind of think about before you start to integrate, or if you're already integrating. There's always ways we can strengthen what we're doing. But I see that those are the biggest challenges as we start adopting this technology.
This reminds me of when we did the beta testing for the Lippincott VR Clinical, and the team asked me to kind of review the product instructions, and I quickly realized how critical they were. The scenarios themselves were absolutely incredible, but my focus kind of through my dean's lens shifted to infection control. How do we clean and store the headsets? What happens if a student experiences motion sickness during simulation? These questions really highlighted a major need, clear printed scenarios to guide educators and students through these situations.
Absolutely. Yeah, I think, when you're looking at using any advanced technology, but especially with, the IVR headset, the hand controls, there's just a propensity for many, many things to come up that can stop a whole simulation session. And, even though we've been doing this for a couple of years now, this fall, we encountered some new things we hadn't encountered before. Because it is still so new, we're still figuring it out. We got a new VR cart that, think of the old charging carts like for laptops, or, you plug it into one big device, plug it into the wall, and they're all charged. Well, not quite that easy.
Yeah.
Because there's different wattages. There's, more energy is needed for the newer headsets than the older headsets. I didn't know this, you don't know what you don't know. And so some of these things we're figuring out as we go, but I'm trying to document all of those things and really share so that, others don't make the same mistakes that I have.
Great insights. I love it. How does this impact faculty roles moving forward? How do you envision the role of faculty kind of evolving as these technologies become more integrated into nursing education? And maybe if you could touch on ideas to how to really orient faculty. We have new faculty, right? They're great clinicians coming from the bedside, but they're novice nurse educators. So this is a lot of new learning for nurse educators. So how do you see that role changing for them?
IVR and AI, and then if you couple them together, it's another tool that we have as educators. So, I think that there's a couple of ways to look at it. Does every faculty do simulation? Does every faculty know the technology that we use in simulation? Maybe, maybe not, depending on your program. You may be in a program where every faculty is involved in that. And then we have programs where we have dedicated faculty who do that. Whichever way it goes, if you're one of the whole faculty who is doing this, we just have to train really well in the technology itself. But that's just one piece, because that's just the tool. Even using AI for data analysis, that's a tool where you follow the same principles as if you're using AI for anything else, right? So it really is that educator piece. And you're absolutely right. I think especially in nursing, we take people who are expert nurses, when we put them in a classroom, but if we've never prepped them of how do you work with students, that's really, really challenging. So I think taking advantage of any professional development opportunity that you can, especially specific to the, experiential learning, simulation, reflective debriefing, I think is something that every faculty needs to understand, because we do so much of that just in our conversations with students, even just giving simple feedback. We want to have that two-way dialogue. Our students today are so much different than they were even 3 years ago, 5 years ago. I've been hearing this as long as I've been in nursing education. Oh, our students are digital natives and they're so different now. It's like, yeah, they are digital natives, but not necessarily in the stuff that we use in nursing education. That doesn't mean they're really a digital native and that they can just walk into any piece of technology, right? I think, we've been talking about this a lot this fall, that our students now, they went through a pandemic at real foundational years, as they're forming social relationships and learning communication and all of those things. We live in a very uncertain world now where our students are facing things none of us have ever faced. So I think we do have just different needs of our learners that need to be addressed. I think that's kind of general to all of nursing education. I think specific with IVR is that I think it can help a new educator because it already provides the consistency, the standardization, the data processing. So then you see faculty, especially new faculty who are learning the role, like it takes all that pressure off of you, because now you can focus on becoming, designing that learning experience, but really helping students make sense. What did they just do? They did a scenario that's common that you've seen in nursing practice. Now they've just seen it in a virtual environment, hopefully replicated.
Right.
It's highly realistic. You have those interruptions, the distractions, all of those things we face as nurses. So then you're able to take that experience that they've had and have a great debriefing and really help them understand, how do I apply this to thousands of patients that I will go and take care of? So I think that, as I go to different nursing education conferences, I used to feel like the young one, and now I feel like I'm the older group of faculty. Like, look at all these young people.
Sure.
That's when you're old, right?
Yeah.
But it's great because we're welcoming them in with better tools to teach. We have these things that can assist them, kind of take some of that cognitive workload off of our educators so they can really spend time thinking about the things that they need to work on to be able to help students, gain that practice readiness and that clinical judgment.
I would love to hear your take kind of on the future of innovation. So if you have a crystal ball, get your crystal ball out there. Looking ahead, what innovations in IVR and AI excite you the most about the future of nursing education?
Well, I think what's most exciting about that is we don't really know, right? I think we've just begun to see what we can do with IVR. So I think as that technology advances, probably someday we'll look back on 2025 when we have these big clunky headsets. So I do think that technology will advance. I think AI, we're all learning about it. We're all learning how to use it better. I think, though, that we can really expand what we're doing with adaptive learning to make it very individualized for each student. I also think that with advancing technologies, we can also help students not just learn in their view of themselves as one nurse taking care of one patient, but to really have an understanding of how they fit into a system. And so, with IVR, we have all of the players that you typically see in a healthcare team. Some of those are really difficult to replicate in simulation because we just don't have that many people or the time to put all of that in there. But in IVR, we can do that. So they have some understanding of what is a case manager, PT, OT, or, even looking at informatics that we are able to provide in IVR. So I think as we innovate, we advance, I think all of that is just going to create a more informed nurse to be ready to walk into the system, and operate within the system. I also think with new innovations and just making it easier to integrate IVR, I think we'll see more of it in the practice side. We're already seeing some healthcare organizations have really latched on and are using that. But there's a lot where it's very new. There's a lot of probably more red tape to get through in a hospital than in a university of just, the security, data safety, all of those things. But I look for that to lessen as time goes on. Maybe we can really bridge that gap as students transition into practice where, our practice partners know this is what we've been doing in virtual environments. Now we're in practice. How can we improve our orientation there using some of this technology as well, making it very individualized?
Right, right. We've been getting a lot of inquiries from practice too. How can we utilize these different technologies to onboard our new hires and build those clinical judgment skill set even more so? Cynthia, as we kind of wrap up our podcast episode here, what is one kind of spark or key takeaway you'd like to share with our audience?
The biggest takeaway that I hope sparks some excitement, some, initiative to move forward, I think is to remember that immersive VR and AI are not about replacing nurse faculty or educators. It's really a tool to help us make student thinking very visible so that we can coach them in learning clinical judgment. We can assess them better. We can measure their progress. And I think this gives us a better platform for moving forward with helping them develop clinical judgment, clinical competence. And so I think that as you begin, maybe you're just starting with either AI or IVR, or maybe the two, start with one outcome. Choose one outcome that you want to achieve with your students and start with that. You don't need a whole fleet of headsets. You don't need to, I said, you don't need to integrate something through the curriculum. Just start with one concept. Start small. And remember, you have your nurse thinking. We have AI, but you are a nurse and you're an educator. So it really begins and it ends with you as the educator.
Wonderful. Thank you so much, Cynthia. I really appreciate you sharing your expertise and your vision for the future of nursing education. So today we explored how immersive virtual reality and AI aren't just tools, they're catalysts for transforming learning, strengthening clinical judgment, and preparing nurses for the realities of modern healthcare. Thanks for listening and keep that spark alive. And thank you again, Cynthia.
Thank you.
Thanks for listening to Lippincott Spark. Be sure to subscribe, share with a colleague, and leave us a 5-star review. You'll find links below to learn more about Lippincott nursing products and services. Until next time, keep learning, keep leading, and keep sparking innovation in nursing education.